Good evening to everyone present here with us today. This is Sriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Ambuja Choranur. Ma'am is MBBS DGO, menopausal specialty in Hyderabad, retired professor and HOD of Ops and Gynecology Department at Osmania Medical College, Hyderabad. With the help of ma'am and her wonderful insight, we will be taking a close look on today's topic, which is contraceptive option of adolescents, addressing barriers and myths. Now, without any further delay, I would like to welcome ma'am at our forum and would like to hand over the session to her. Ma'am will join us shortly. Before starting the session, ma'am has few questions for our audience, which I will be displaying on the screen. So, the first question is definition of adolescence. Second question is what is LARC? Third question, major barrier for contraceptive services for adolescents. Fourth question, what is failure rate of LARC? Fifth question, which country has large number of adolescents? These are the questions from our ma'am, which we want answer from our audience. By the end of the session, I will be collecting the answers. Hope ma'am will be join us soon. Thank you for the patience. Ma'am is here with us. Welcome, ma'am.
Yeah, good evening, everybody. Very happy to see you all, though I'm not able to see you. But today's subject, contraceptive options for adolescents, is really very interesting and very important for everybody. I think all of you agree with me. Compared to yesteryears, nowadays we are getting many adolescents for contraceptive advice. It was not there, it's about 10 years back, and so much of change is present in the society. They are coming forward to ask for the contraceptive advice. They are asking for the termination of pregnancy, so many things. So now it is up to us to tell them what is the update that is available and how much we'll be able to help them. I think all of you have answered these questions what I gave you. The second question is what is LARC? Okay. How many of you have answered? Can you raise the hands? How many of you did this? I think many of you are very much aware of these questions. You would have answered very well. So, according to the WHO definition of adolescence, it is 10 to 19 years for the girls. And adolescents nowadays, the government of India had added young adults also into this group because the vulnerability of these up to 25 years, vulnerability of these girls is the same as 10 to 19 years. So for some of the statistical purposes, they made it into IAS. 30% of the global burden of the diseases has roots at adolescence. Means either you take infertility or HIV, AIDS, or for the burden of carcinoma cervix. Nowadays, the incidence of carcinoma is we are able to prevent because of the primary immunization. But it is a viral infection that is there, especially when the transformation zone is forming. That time exposure to the semen, definitely if it is positive for HPV, it is going to be positive for that one. So many diseases have got the roots at the adolescence that we have to know. And why this is important, adolescent period is, the this is the period where mental, social, and physical development takes place. It is not only the person who is attaining the menarche and the consequent menstrual problems, but all the other problems are also arise. They are so hyperactive, and they want to search and do the research of their body. They want to do the experimental things because of the hormonal influence. All these things are there, so they are all the vulnerable people. In India, it is 243 million adolescent children aged between 10 to 19 years are there. Whole of world, if you take, India is the first one where adolescents population is more. It accounts for about 21.3% population of the country. Girls currently married in that group is 30% in India. Boys currently are less, it's about 5%. Birth by the age of 18 years is 21.7%. We see many girls by the age of 18 years, they have two children, they are already sterilized. Such a vulnerability because the perinatal mortality is more, but still the girls are sterilized. They don't have any option to have the further things. These are all the things that happen in the rural areas where they are not informed properly about the contraception, conception, and what methods they have to follow. This is the end result of it. That's happening like that. So we have to give them about the proper knowledge of what is the birth and contraception, interval contraception, what is the permanent methods of contraception, and all these things we should give the knowledge about them. So, population wise, all over the world, if you take India, I told you India is the first thing, but percentage wise, suppose if you take population and number of adolescent things, you take Pakistan, of course it starts first, but number wise India is the first, and next to India is China is standing. What is the sexual behavior and unintended pregnancy in the adolescents? We don't have statistics in India very much. I'll tell you the same with my experience of 35 to 40 years. The promiscuity and extramarital relations were present even in the yesteryears. But nowadays, because of the education, they are coming forward to ask the questions, and we, as an independent India, we are able to help them in so many ways. This is there, but we don't have a correct statistics. These are the statistics from the Western countries. The median age of first intercourse is 17 years for them. By the age 18, 60% of the females have had a sexual intercourse, and by the age of 20 years, almost 80% they have the intercourse. Many have had more than one partner. Adolescents have the lowest level of contraceptive knowledge and use. Even in Western countries, it is the same. Though it is available everywhere, the knowledge they don't utilize that one. They are all at higher risk for all the pregnancy complications, unwanted pregnancy, and sexually transmitted infections. Although there appears to be an increase in contraceptive use at first intercourse, many adolescents do not use any method of contraception at first intercourse, or they do not continue to use contraception continue consistently, they don't use it, and the consequence of it is unwanted pregnancy. And every year in India there are 3 million girls aged 15 to 19 years undergo unsafe abortions, because even though it is available in all the government hospitals, Family Planning of India, and so many non or I mean NGOs are doing help for them, but still they don't come forward to utilize that service because they want privacy, they want confidentiality, which is lacking in all these things. So that's why they are so much afraid and they will indulge in all unsafe methods of abortions. In India, adolescent birth rate is 71 per thousand. So many people are giving birth before, in the age of 15 to 19. And another risk factor is babies born to the adolescent mothers, they are not grown up properly. Nutrition is not good. They are the risk of dying prematurely. Prematurity is very common, and perinatal mortality is also very common. Unmarried adolescents are likely to resort to the unsafe method of abortions, which increases the risk of complications like septicemia and also mortality. This septicemia, I do remember in my student days, we used to see people coming in such a bad condition because of they used to insert all sorts of materials for the sticks into the uterus to cause abortions, which was leading for the infections so bad where people used to die in front of our eyes. Young men, girls, they used to die in front of our eyes. So, but that I think we are able to control that. We don't see such a bad septicemia very frequently nowadays. And early pregnancy and childbirth, of course, complications. All of you know during pregnancy, like preeclampsia, preterm labor, prolonged and obstructed labor, because they are not very well developed anatomically. And second thing is postpartum hemorrhage, that is the dreaded complication that is there. If you take the contribution of fertility, 52.5% of countries' fertility is contributed by the age group of 15 to 24 years. Astonishing, no, this figure really. And 46% of the maternal deaths will occur in that age group. Factors that increase the risk of early sexual activity in adolescents is one, very poor, no education, and rural areas they are living, and especially single parents children, they don't have so much of intimacy with the parents. That's why home atmosphere is very very important. If they don't have it, they indulge in all sorts of things. And risky behavior like smoking, alcohol, drug abuse, and having sexually active peers. This is very, very important. Most of the times, these adolescent girls, they will listen to their peers, not with the. Just hold on 1 minute. ప్రేమ్ సార్ ఉన్నారు ఇంట్లోకి వచ్చేసి సార్ ఉన్నారు సార్కి ఫోన్ చేసి. So this is another thing that will happen. So uh, what is the solution for this? So the family planning is the solution for them, and it prevents unintended pregnancies, unsafe abortions, and high risk pregnancies. And the mortality, child mortality is three times more, and maternal mortality is also more. For every woman who dies of pregnancy and childbirth complications, the morbidity is 20 times. Always we are seeing the mothers dying only, but morbidity, because of this they are suffering. And now I think it is less, but VVF, RVF, and whatnot, additions, PID, and infertility, all these things are very much rampant thing. So the thing is, we need to prevent all these things, means we should follow the family planning methods. Yes, I gave you explanation why it is necessary, what is the adolescent behavior, and what are the consequences that are there. So the next question comes, yes, they are ready to accept. Are we ready to give a proper information to them? That is always an unmet need for the contraception. There are so many contraceptive methods that have come into existence, but none of them are able to stand to their expectations, because There are so many challenges: fertility, pregnancy, I mean, if you select one contraceptive, that should fulfill all these things. Are they are? Is it doing? That's what is the question we should ask. So, the characteristics of an ideal contraceptives are listed below. I just want to repeat this so that you will remember. All of you know very well, but still I want to repeat because we should never forget these things when we are prescribing a contraceptive. First and foremost is the confidentiality, and it should be highly effective, should not be any side effects, independent of the sex, and it should be independent of the healthcare provider. They should not interfere, and I told you, it's the confidentiality, that's what is very important. They don't want to reveal themselves to anybody, and it should be reversible, and it should be cheap. Suppose if you take Mirena or Copperty, which are little costly, they will not be able to afford. Or if you take oral contraceptive pills that are there. Of course, in India, it is good that government is supplying, but again, the supply from the government most of the time they are having either vomitings or and side effects are there, and they have to reach the family planning and services to the hospital or anywhere, and they are not easily available on the counter. These are all the problems. Availability is a acceptable to all cultures and religions, everybody. Because if you take MTP, many of the religions they don't agree. Jews definitely they will not agree, and adherence to the particular contraceptive is very important. Stop sharing. Stephen sharing. Is sharing your screen. Shall I do this? Stop sharing. I don't know. Yeah. What are the barriers to access and use of contraceptive services for adolescents? First and foremost, the laws are like that. Many people are not aware. They don't digest. Many of the seniors like me, they don't digest that unmarried people having a sex. We don't digest, thinking that everybody is so good, but it is wrong. They have the hormones. They have the liberty, so they do involve in the sexual activities. We should accept and guide them, not to uh, they say that policies are not meant for you, so we will not give. And gender and social norms, all of us know ours is a male dominated society, or male people, they don't allow them to go out or do anything. That's why chupke chupke. These things are done, and consequently, who is suffering? It is the girl who is suffering. And what about the misconceptions and lack of knowledge? Yes, everybody will think if you use either intrauterine devices or oral contraceptive drugs for a long time, the main thing they are worried is the fertility in future will suffer, and they will get cancer somewhere, or they will get the bleeding problems, what not. So many things they will think themselves without asking the proper concerned person. And financial barriers, I already told you. Even everyday buying or everyday spending money, initially spending some thousands, because they are not earning people. No, it's become so difficult for them. Lack of privacy and confidential. This is the main thing. Girls, they don't reach out anybody, neither the parents nor the teachers. They don't discuss with them. Who is left to them is only peers, who give the same, who have the knowledge of the same like them. Whatever the knowledge they get is from the Google. So this is not proved. And providers also, so many times they will not treat properly. That's the reason why it happens. They are not able to utilize the services that are available. So if it is like that, who are the best sexual reproductive health system educators to teach? This is what is very important. Providing information for healthy choices is, but first and foremost, is the mother. She is the most influential sex educator for teens. She will teach about the abstinence. She'll teach her how to prevent unwanted pregnancy, how to prevent sexual transmitted diseases, and she will tell about the options that are available. The next person is the pediatrician. The first and foremost, they reach the pediatrician who takes care of them every year when they go. They should make an attempt at that time itself. They should tell about the immunization. They will tell about the when availability of all these things. So this is the next is the pediatrician. Next comes is the teacher. So I'll give you an example how to go about a 19 years college girl from a good family background. They are all my cases only. And studying in the hostel, she's there. Had one sex with boyfriend, a known person only. Came for counseling. She wants to continue with him for 2 more years without marriage, and she's not sure whether she will marry the same boy or not because her father is in a very big position. And what is best for me, she asked. So what am I to answer for that one? So contraceptive options depends on what? One, patient is married or unmarried. If she is married, because below the 19 years, so I told you so many 30% of them are married and having the children. Is it for spacing or for postponement of the first pregnancy or postponement of the second pregnancy? If she is unmarried, you should find out whether she is indulging in regular sex, occasional or multiple partners are there, access to contraceptive services, education. I already explained whether it is a rural or urban, and her socio-economic status, confidentiality, and you have to solve her myths and misconceptions. So we have got so many contraceptive baskets. What I told you, the first and foremost is reliability and acceptability of the contraceptive method what we are using. You see this uh, see, the first most effective contraceptives are the implants and intrauterine devices because their failure rate is less than 0.1%, means less than 1 per thousand women the failure rate means pregnancy can occur. But whenever any failure in that implant or long acting intrauterine device is present, usually always you have to exclude ectopic pregnancy further. Next comes is all the other methods, the injections, intramuscular injection or subcutaneous injections, Depo-Provera what we are giving, or the contraceptive pills, the hormonal contraceptive pills, or the patches, or the rings, diaphragm, what they are using. The intermediate, their failure rate is about 4 to 7%. It is quite high. 4 to 7% is really unacceptable. Only thing is you have to use the pills. Of course, we say the pills is almost 100% safe, but using the pill is a regularity. So these are all the statistics showed that 47% failures are there. They are not the method failures. It is because of the consistently using is not there with these methods. That's why it's a failure rate, and it is the user dependent. If the person is using, she should be very regular and she should use daily if it is a contraceptive pill, and if it is an injection every 3 months, she should go and take a shot, which they may not do it properly, and patches, especially a country like us where the moisture is more, summer is more, it will not stick properly to the site. That is why the failure rates are also more. It is the same for the ring or the diaphragm also may not use it properly. Then comes the highest failure rates, means it's the least effective one, that is the condoms. Almost 13 to 20% is there, male or female condoms, and fertility failures and spermicides what we are using. Suppose one more thing we have to think of is, if all these fail and if they get pregnancy, what we should inform them is about the emergency contraceptives. So this basket now it is expanded for family planning choices. The new contraceptives have come into the thing, that is the injectable contraceptives, and that is the subcutaneous medroxyprogesterone is there, where the patient can take injection by herself. Still it has not started, and the Indian government has given recently, it has accepted, but it has not become the rule still. And another is the centroman, which is given only in India. Other FDA is not approved. India, of course, government itself is propagating. This is called the Chaya program. And progesterone only pills. It is for adolescents. It is under trial. And another new introduction is the copper IUCD 375, effective for 5 years, introduced in the program in 2012 and 2013. The one copper UCD that's available with Government of India is 250, which is for 3 years only. This we can use it for 5 years. And another one is introduction of a new method, postpartum IUCD. All of you would have heard, with so much of things, we are not able to cater everybody. So that's why, with their consent, immediately after delivery, this postpartum contraceptive is introduced to the uterus, and it provides again the same 3 years program, and if it is a 375, it is for the 5 years. And another is the Saint Cromon, that is the one Antara program that is there. So in India, if you take adolescent program, most of the people, what they are using is this, the statistics that is being taken, male condoms are injectable ones. They have not accepted any other method until now as a choice. And condoms, especially at first intercourse only, they are using, but consistently they are not able to use it. If you ask, as a general, what is the preferable? You have shown me, madam, so many things. What we should advise them, my dear I mean, friends, you listen to me. Adolescents are eligible to use any method of contraception, and LARC, which is the best. I'll explain you what is LARC, and which are forgettable. Once you insert and once you start, you will forget about it. Highly effective, may be particularly suited for many adolescents. So, what is this LARC? Long acting reversible contraceptive is the LARC. So advantages, I told you, it's already highly effective. 3 or 5 years it is there. Injections at least once in 3 months. It's a long term without any effort by the user. Rapid return to the fertility it is there. And this one, LARC, the first line contraception endorsed by International Obstetrics and Gynec Society, and American Pediatric Association, ACOG, that is American College of Obstetrics and Gynecology, WHO, especially well suited to adolescents and young adults who have the highest rates of unintended pregnancy. So, all of you know now what is LARC. So, LARC, what are all the things that will come under LARC? One is implants, that is the Nexplanon, intrauterine devices, that is copper UCD, and levonorgestrel intrauterine system, LNG IUS, levonorgestrel intrauterine system, injectable dipomedroxyprogesterone acetate 150 milligrams IM for 3 months, and subcutaneous. I will just explain you all these things. Remaining all, natural methods and all those things which we are not very important, one thing. And second is what we are using, I want to explain. And one thing what you should understand is age alone is not a contraindication for any method. Again, in the beginning it's all told, now also again telling, just because she is a adolescent girl, we can't deny her of any of the things. But what is the best is the long-acting one. I am going to explain. The reasons for underutilization of the LARC, I told you, They are not using, except for the injections and for the condoms in India, they are not using. Of course, in foreign countries, people are using. What is the reason? Lack of knowledge among women about LARC, not only for the women, but even the healthcare providers, doctors, nurses, ayas, or for the other people, they themselves are not aware that such things are available and we can uh, utilize them. And women's misconceptions and misinformation. Always they think if they use this lot when long acting ones, the fertility will not be returned, they will not have the menstruation normally, they will not have future children, so many things. They will put on weight, they will have vomitings, this thing, that thing. So misconceptions and higher initial cost of the method. Yes, definitely it is there. If you think of intrauterine device, it is about 3 to 4 thousand rupees. It is there, and implant again it is costly. Somewhere about 3,000 something is there, and for all these things, no, there is placement procedure. They should depend for the placement on the healthcare provider, and dependence on the provider for information provided by bias against the method also is there. Any method you think, as a healthcare provider, we have to answer four things. Any method. Efficacy means that is effective. How effective it is, I already showed you the chart, what are all the things that are effective, and what are the risks, what are the benefits, what are the side effects. If you answer four things well, whole knowledge is being done. Only four things. You take the implant. Yes, it is highly effective, 99%, and no cardiovascular risk and no cancer risk for that one. And it is quite useful for the patients, girls having the endometriosis, dysmenorrhea, ovulatory pain. But bleeding problems, irregular bleeding points, sometimes heavy bleeding, acne, mood, weight gain, some of the things are there. That is why many people they discontinue using this method. But still, you should know about this one. It is widely utilized, and maybe about 3 4 years we are also using. And recently, also Modi discussed about this in the Parliament. They want to implement and get it into the purview of the government so that it can be utilized. They were thinking, I think so, but still it is not in the government supply. But once in a way, in the Family Planning Association of India, they are getting through the donations and then they are using this one. So, what is this implant? We will see. You are able to see this. No, this is a thin, flexible plastic implant. You are able to see in the hand. This is only of this thing, and the hormone called the etinogestral is there, which prevents ovulation. The implant is about the size of the matchstick, and it is placed under the skin subdermal of the upper arm. I'll show you how to put it. Many girls will accept because they are not touching the private parts and it is easily inserted. Nearly 100% effective at preventing pregnancy with the typical use if they use it properly. It provides safe long term birth control. Adolescents don't have to remember to do anything every day, week, or month to stay protected from uninterrupted pregnancy. The example what I told you, the girl wants to have regular intercourse with a boy for 2 years, it is the best she can go about it. And compared to see the to satisfy people and to prevent complications, so many amendments, so many improvements are being done. One of the improvements that's being done is that barium is impregnated into this. So in case if it is missed or goes somewhere, you can take a X-ray and you can find out where that is there. And it should be replaced every 3 years. But only disadvantage I told you already, it is the irregular bleeding. If pregnancy happens with this in situ, you have to exclude the pregnancy. Implanon, it contains 68 milligrams of etrogestral and comes preloaded into a needle as a disposable injection delivery system or applicator. It is inserted under the skin of the upper arm allowing controlled release of an ovulation suppressing hormone etrogestral 30 micrograms per day for up to 3 years. You remember etrogestral, that's more than enough. Even if you don't remember the numbers, you remember etrogestral is the hormone that is there. So this is how they will give in a non-dependent hand. You see, most of the people, we are all right-handed people. So left hand, you put it under the your head, near the head, and inner side of the non-dependent. Are you able to see me doing here? Because we regularly we give training for the PHC doctors and all how to do it. Very simple procedure. Once you learn, we can do it in 15 minutes. And you selection of the site. The first of all, you how to do it is very important. Inner side of the non-dependent hand. You palpate for the medial epicondyle of the humerus and make 3 marks. How do you make it? 1 mark you should go for 6 to 10 centimeters. This comes to this. Above you make a mark. One is medial epicondyle, the second is this, and again 3 to 4 centimeters above that one, you make another mark. The third mark is because if you hold this, it should go only in this direction. It should neither go this or go like this. This is why that is important. Means here, you know what muscles come. This is the biceps and triceps. There is a groove where a major vessel goes. So you should not damage that vessel. That is why you have to mark for every case. Even though you are very much trained, you know very well, because you know the fat people sometimes it varies, and thin people it is very easy to pick the nothing. But the thing is, one, remember medial malleolus, and 8 to 10 centimeters above that, there's one mark where you are going to prick. Another one is about 4 centimeters above that is the other one. So, with the marking pen, always it should be there. Anything should be done under all aseptic precautions. And one thing you remember, and there are adolescent girls no going to have a future mark. Don't insert into the mark point. Go either above or below, because that one, if you insert needle prick, if it is there, it gets absorbed and becomes a permanent mark. That's why you should be very careful. And under local anesthesia and all aseptic conditions, betadine cleaning and all with a sterile towel, inject local anesthesia, Zalecan 1%, and then insert the needle. There is a special needle. You are able to see this needle here, and at the insert at 30 degrees and then rise, so that the needle that will go subcutaneously. And the third, the mark that is there, this guides the needle so that it will not go deep inside. And once it is there, we can just take out the applicator. The needle is there, and ask the person to palpate the needle so that she knows that that is there. Normally it is not seen outside unless the patient is very thin. And don't forget to give the discharge card. It is outpatient procedure only. Discharge card where her patient's identity, that name and all these things we are going to write. You mention when she should come back, and if she gets any reaction, there will not be anything. Sometimes, xylocaine that they are giving, anything is there, they should be able to reach you for that one. This is what is the procedure. And anybody wants training, you can call me or come to me. I don't know from where you are all. Is there any family planning services, Family Planning Association of India? If you reach, we'll be able to give. The question is, this implant is best for whom? Anybody spacing method they want, and especially for adolescents. And this is a progesterone. Etrogestral is a progesterone where estrogens are contraindicated, because combined contraceptive pills has got both estrogens and progesterones. That is why where estrogen using is contraindicated, like thromboembolic complications or deep vein thrombosis, if they have anything like that, those patients you can use. Or when they use it, they get a migraine attack, like using the estrogen migraine if they get it. Menorrhagia for using IUCD, the main problem is the bleeding problems. In such cases, we can use the implant. Suppose if amenorrhea occurs after using this problem, what is the answer what you are going to do? One thing is you put the implant immediately after the periods. Make sure that when you are inserting, patient is not pregnant, because pregnancy which is there previously, it can continue, one thing. So, or with this, if it is not placed properly, then also a failure can occur. So exclude pregnancy. And second thing is, after about 6 months, if the patient goes in amenorrhea, you tell the effect of using the progesterone is any time on the endometrium is, this is the decidualization, means endometrium, like atrophic endometrium, desensitization happens. That is why, unless it is stimulated with the estrogen, again it will not bleed. So it's not a problem at all. The one difference between the implant, I mean, etrogestral and dipamidroxyprogesterone, which we use for the intramuscular contraceptive, is sometimes with the intramuscular contraceptives, they may go in for amenorrhea, secondary amenorrhea for a long periods, and returning to the menses will be delayed. But here, that problem is not there. Once you remove this implant, it will return to the normal. So fertility returns immediately after removal. This may not happen sometimes with the intramuscular injections. That's why it has become a failure. Actually, Government of India introduced that intramuscular one into the government programs, and they used to give all the delivered people 6 weeks after delivery injection they used to give. But so many people, they have gone in for amenorrhea and infertility, that has become a failure. And you can switch to another method if you want, immediately you can do it. And return of menses is immediate. I hope I made understand this implant how useful it is. And this is the one which we need to propagate for all the adolescents who are indulging in the sex. And second, this is about the implant. And now, one is the levonorgestrel intrauterine device. This is the levonorgestrel intrauterine device here. This is the copper T which is supplied in the hospitals. This levonorgestrel intrauterine device is about 4,000. It's not supplied by the government. Again, if you take it as efficacy, highly effective. In the first beginning figure itself, I showed you how effective it is. Health risks, again, this is a progesterone that is there. For a young girl, the health risks are very minimal. But if you give it for the elderly person, this only has got some effect on the lipid profile, but otherwise it is the local action that happens. So levonorgestrel is very good. And second thing is, anybody having the problem of irregular bleeding, even if the married, it's very good. Unmarried, the insertion of it is little problem because of this. When the stem, which is little bigger, more than 4 millimeters, that is there, you have to dilate the cervix little. That's why we do it under local anesthesia. Or if she is very much scared, but still if they want means, we can go for the general anesthesia also. But still this is very good. Local action is very much. And complications, again, because it is like an intrauterine device, irregular bleeding that is there like copper T only. For the first 1 year, little irregular bleedings will be there, but afterwards, they become all right. And they will go in for amenorrhea. Even if they go in for amenorrhea, once you remove the intrauterine device, because of the hormones that are present in the body, estrogen priming of the endometrium, that one leads to the normal menstruation. So we call it as a magnetic stick, because Here I am showing you for the adolescent contraception, but it can be used for endometriosis, adenomyosis, or a small seedling fibroids going in for menorrhagia or anovulatory bleeding. All these things, but you can use it. But here, I think. And the next question comes: can we use intrauterine contraceptive devices for nulliparous women? Yes, it is approved by the FDA, that is Food and Drug Administration. You can use it, and no more infection. There is infection anytime if they have sex, but not more infection compared to normal sex. That is what is the thing. The progestin releasing intrauterine system, it's a T-shaped one, contains 52 milligrams of the levonorgestrel and releases 20 micrograms of LNG daily. And it's a local action. And the endometrium goes in further almost to the level of the arteries. It prevents growth of the endometrium by decidualization. So, mm, is almost, we can say, safe in India. Unmarried, nulliparous women are not accepting any of the intrauterine devices, and married, yes, they are accepting. I'll tell you, the defect lies with the healthcare provider also, because they are not mentally accepting this for the nulliparous person. That's why they are telling the nulliparous one, don't use this. But many of the countries, especially UK and Australia, they are using very regularly for all nulliparous women also. But in India, still, there are so many hurdles will be there to satisfy a person is also a difficult. It's a pre-sterile one, and this has to be inserted under all aseptic conditions. We can use either local anesthesia or without anesthesia also. But LNG always better to use give anesthesia, because it needs little dilatation of the cervix. Always, I think, I hope all of you are MBBS. What you should know is the dilatation of the cervix is more painful and people will go in for shock. But cutting the cervix is not painful. Cutting the uterus is not painful. That is why when we were doing cesarean sections, we used to anesthetize only the cesarean sections when type of incision or peritoneum or anything. But no anesthesia is given to the uterus, because cutting the uterus is painless, and dilatation or distension of the uterus is painful. That is why hydrangeas is more painful than doing the cesarean section. And cervix also, if you dilate without giving anesthesia, there's so many times they will go in for shock. Your anesthesia is either paracervical block or the local injection also, we can use it. If it is so good, why it is not accepted as expected? This is what is the one. As it is, the healthcare workers are not believing it, and they are not accepting themselves. That is why they say you are unmarried, you are nulliparous, that's why you don't use. They themselves will discourage the one. But this is an unknown anxiety and fear of unknown, especially unmarried, imagining this thing will happen, that thing will happen. Horror stories from the Google and neighbors and from the peers. And the second problem with this is, any problem that arises, they need to come to the doctor, which is really painful for them. And not for acute heavy bleeding. If they have, they cannot continue this. And complications, I told you, is very very less, but they do occur. We should be very aware of the complications. The first and perforation is very rare, but it can happen. 1 in 1,000. Expulsion also, it is the same. And especially, yeah, irregular bleeding, spotting, and so many times with this, because it is the progesterone hormone that is there. Ovarian cysts can occur. And nowadays, every person has got little pain or no pain, pain or white discharge, anything. The first thing they'll get the prescription for the ultrasound, because everybody in India they will prescribe either RMP doctor or a surgeon, or even staff nurse. Anybody can write. They go and just get it done. Ovarian cysts are very there because of. But only thing is we need to counsel them and tell what is the problem. So, how to improve the acceptability? One, you teach your brain that you should accept this, and second is you should be well trained person. Don't haphazardly do it properly, follow all the protocols, counsel the patient properly, take the consent, and maintain the confidentiality. And technique is very very important, and identify if there is any problem she comes, please take care of the person. Just hold on 1 minute. అమ్మ మీరు తర్వాత ఫోన్ చేయండి, నేను బిజీగా ఉన్నాను, లేకపోతే సార్కి ఫోన్ చేయండి. So, counseling is very, very important for them. The next one, I told you implant, I told you intrauterine system, and copper T also we can use it. And any method if you use, what is the efficacy, what are the health risks, what are the benefits, and what are the side effects. If you answer these things, this is also very good property, but only thing is it has got the problems of bleeding now and then, and perforation also is a possibility that is there. That is why one of between the two we have to choose. And now coming to the injections, I told you dipomedroxy progesterone people are accepting now. This is again a progesterone, dipomedroxy progesterone that is there, and uh, this one, if 150 milligrams is there, dipomedroxy progesterone intramuscular, it can be given once in 3 months. But now it is come as the dipomedroxy progesterone subcutaneous. That is, previously injectable contraception involved an intramuscular injection of the progesterone only drug, that is the dipomedroxyprogesterone, every once in 3 months. The new subcutaneous administration route is injected under the skin and uses a smaller needle size delivering 104 milligrams of medoxyprogesterone acetate. How much is the intramuscular? It is 150 milligrams per 1 ml. This one 104 milligrams per 0.65 ml, that is less than 1 ml. Both methods are equally effective in preventing pregnancy when used correctly and consistently. Means every 3 months before it gets expired, you have to get a second shot so that the pregnancy is prevented. It offers added advantage of potential self-administration by an individual in countries where it is licensed. For us, it may come in coming future. Mean like people who are diabetic, they are taking the subcutaneous insulin. Like that also, this is also user can take by themselves. It is really good if it comes the subcutaneous injection. So, unmet need of contraception, Fox's statement in line with WHO recommendation is to make DMPA subcutaneous available, or FOXY. This is Federation of Obstetrics and Gynecology of India. It encourages and endorses the use of DMPA subcutaneous dipomedroxyprogesterone or DMPA SC, an injection, self injection in several parts of the world as an effective, safe, and acceptable method of contraception. So, Foxy also is going to recommend now. It is 99% effective in preventing unwanted and unintended pregnancy if used correctly. So, the next one I told you is the scent chromone. This is the one with this is called Saheli or Chaya, which contains ormeloxifene. This 30 milligram tablet, Saheli. So it is a non-hormonal, non-steroidal oral drug. This is this is a sum, that is estrogen receptor modulator. Estrogen receptor modulator available, free in family planning, safe, and few side effects are there. 96% efficacy. Dose is one tablet twice a week for 12 weeks, then one tablet weekly. Can be used as an emergency contraceptive also. I'll explain you what emergency contraceptive. The Centraman is working so well in India. Many times people they don't come back for the follow up or checkup also. They continue using it. And if you take this is until now we were talking only about the progesterones and the SERMs, that is estrogen receptor modulators. But now this is a combined method. All of you know, I'm not going into the details because these are all which we know. The pill patch ring, among them, the pill only is very famous, but only thing is using consistently for the adolescent girl is difficult. They will forget. So pregnancy rate is 4 to 7%, which is unacceptable. And estrogen side effects also will be there, and breast tenderness, headache, irregular bleeding, and some of the complications are present. That's why, when though it is very good, not used properly. So, what is the most appropriate method of contraception for adolescents? Long-acting reversible contraceptive methods have higher efficacy, higher continuation rates, higher satisfaction rates compared with short-acting contraceptives because LARC methods are safe. They are excellent contraceptive choices for adolescent. This is not me I am telling. This is endorsed by the ACOG, APP, and FIGO. I already told you. So, one thing what we should understand is none of these things they will protect the person against sexually transmitted diseases. What is the best sexually transmitted diseases we use? It is the condom. So, condom plus any of these methods is the best. The question. What if condom? Next question comes. That is over. We answered that girl's question. What is the best for you? Next person, she came and asked me why when using the condom broke or she forgot a pill, not used any method, or it is an unwanted sex, it happened. Already it is over. What is the solution for that one? How are we? See, we can't say, no, no, you go, and if you become pregnant, you continue with the pregnancy. No. You should be very compassionate with the adolescent girls and you should solve their problems. If all these problems come, what is the answer from your side? Yes, there is answer. That is the emergency contraception. But for you also to understand, I'm telling, it reduces the chance of pregnancy after unprotected sex. But emergency contraception will not cause abortion. If pregnancy already occurred, this will not work. That we should make them understand. If the patient is on 28th day of the cycle, where pregnancy has already, ovulation has happened and pregnancy has occurred, means if she comes late, this is not going to work at all. Only if there is no pregnancy and to prevent unwanted pregnancy, this will help. And it is not abortifacient. So, what are the myths and misconceptions with the emergency contraceptives? Are emergency contraception causes abortion? Will it? No. Emergency contraception permanently disrupts your menstrual cycle? No. Emergency, you need to prescription to receive emergency contraception. Again, it is a tricky thing, I'll tell you. Once upon a time, government made it available on the counter. It so happened people started using it without seeing whether they're pregnant or not as a abortifacient, and so they used to go in for irregular bleedings and all sorts of things. And suppose if she is pregnant, ectopic used to rupture and they used to get into the problems. That is why it's not available on the counter. Of course, India, I'll tell you, the pharmacists have no control. Whether you prescribe or not, they will distribute the drugs. You can use emergency contraception as a long-term birth control method. Yes, you can use it. You will get really sick from taking emergency contraception? No. So, what are the methods that are available for the emergency contraception? One, levonorgestrel 1.5 milligrams single tablet. It should be taken within 3 days of unprotected intercourse, and if it is approved by the FDA. This is, yes, please remember, progesterone, this is progesterone only pill, levonorgestrel 1.5 milligrams, a single tablet taken only once, up to, it protects within 3 days of unprotected intercourse you can take. Suppose if you are taking the tablet, if you get vomitings and if you vomit it out, please repeat the dose one more you can take. And suppose a continuous vomiting you are not able to tolerate, go switch on to some other method. And the next comes is the ulipristal acetate 30 milligrams. It can be used within 3 days. This is a selective progesterone receptor modulator. The one which we used is the selective estrogen receptor modulator is the one, and this is the selective progesterone receptor modulator. Ulipristal 30 milligrams we can use it, and still it is on the way to come for us. We are not using this one; it's not available with us now. And another is the copper IUCD. If it is inserted within 5 days of unprotected intercourse, they will get the menstruation. And centchroman 2 tablets, each 12 hours apart, within 2 days if you give, that's also going to cause the menstruation. A little bit about the ulipristal acetate, which is a very good drug if it comes into the market to us. It's not used in our country, but other countries are, Western countries are using. I just want to discuss about this and tell you little about this one. It is a progesterone receptor modulator. So ulipristal is a derivative of 19-nor progesterone. Where else we use this 19-nor progesterone? All of you would have read this as an MBBS itself is a 19-nor testosterone is a very good styptic action that is there. If menorrhagia is there, suddenly if you want to stop bleeding because of the ovulatory disorders that is there, that's what we use it as the registerone. That's again 19-nor testosterone derivative. Selective progesterone receptor modulator is the 19-nor progesterone ulipristal acetate, and one tablet to be taken orally as soon as possible, and it should be taken within 5 days. If vomiting, again the same, you have to repeat. And how it acts: inhibitory effect on ovulation when administered during the follicular phase. So I told you the other drug which you are using, it will not affect one once they are pregnant, but here if they are in the ovulatory phase also, you can use it if there is no pregnancy. Means if it is in the follicular phase, it will stop the follicle to grow. If it is in the secretory phase, it prevents follicular rupture, and it prevents ovulation. This is a very good drug. And only thing is, some of the drug interactions are there with the barbiturates or the anti-epileptic drugs, carbamazepine, phenytoin, and the drugs like itaconazole or ketoconazole, antifungal drugs which you are using, it reactions will be there. Allergic, some of the antacids which we are using, you should be um, uh, drug interactions are there. Better not to use with those things. The side effects like any other hormones that is there, like dizziness, headache, vomiting, nausea, any hormone, any drug you take, these are all the side effects is there. So why I am telling it's a good drug is a comparative study that is being done in Australia. This is recent only, it's about 5 years back. They compared LNG IUS, that's a single tablet levonorgestrel 1.5 milligrams oral single dose and ulipristal acetate when they used it within 24 hours. The pregnancy, if they use it, the occurrence of the pregnancy is very low with the ulipristal acetate, even with the 72 hours or 120 hours also. Compared to LNG, the ulipristal has got a better effect. Efficacy wise, it is very good. So these are all the references for that one. And I thought I covered so many things. More than this, it's very difficult for you to. Please call me after an hour. Thank you very much for the patient listening. And whoever is from the clarinet side, can you focus the questions again?
Sure, ma'am.
Yeah,
So,
the
ma'am,
same
you have
thing.
asked.
After listening, just 1 minute. After listening to my lecture, how much they are able to answer all the 6 questions. You post the questions again and see the result. Is there any difference?
Sure.
And now I am ready to take the questions.
Okay. So,
Yeah,
ma'am,
how
the
to.
first question which you asked was
Yeah,
a
I'm not
definition.
seeing here. None of. Can I see the audience?
No, ma'am, you won't be able to see the audience. You need to go back to yes, yes.
But
I
I will
hope
see you only. Is that Rayan?
yes,
Your beautiful face
yes.
is seen.
Thank you, ma'am. So, ma'am, I have flashed the question. So, the
Ah,
first question was definition of adolescence. Was your first question, right, ma'am?
ah,
So, we did receive one answer from our audience. Her name was Nobonita. She
yeah.
have answered this question. She has said, an adolescence is a person between the age of 10 and 9.
10 and 19.
19, sorry.
Yeah, it is correct. I think at least one person answered. I don't know why the others have not answered.
That's the
Yeah,
only answer
next.
we received from Nobonita first, ma'am. And the second question which you asked, what is LAR? Right, ma'am?
Yeah.
Yeah. Again, she has only answered it. LARC stands for Long Activity Reversible Contraceptive.
Is it the only one person attending the lecture today?
No, no. Some person, few people did join, ma'am, but only few people have answered. Two, three answers we have only received
Okay.
on YouTube. So, ma'am, the another question which we have received the answer of was, yeah, which country has large number of adolescents? The answer was given by Shoheli. She have answered it as India has the large number of adolescents.
Oh, happy, happy. Is Navanita from Warangal?
No, she is from Kolkata.
Kolkata. Okay. Hmm.
Yeah. So, ma'am, that's all the answers we have received. So, we are almost at the end of the session, ma'am. Before concluding, ma'am, I would like to thank you for joining us today, and it was a wonderful presentation. Ma'am, any take home message from your end before concluding?
Yeah, so many times I gave the take home messages. Don't neglect the adolescents. Don't make them go for the unwanted pregnancy and complications, and maintain the confidentiality with all the adolescent. And first and foremost is you yourself get trained. Train your brains that you need to accept the present day and advise them about the contraception. Whoever comes to you, don't say that you are unmarried or you should not have sex. This is all is a bala bala, is a waste thing. You should not talk. You tell them how you are going to help them. And because the implant is a very good thing for the adolescents. So you learn, all of you, how to put that implant. Is very simple. Within 15 minutes you can learn. But only thing is insertion and removal also you should learn, and you have them. That is the advice.
Thank you so much, ma'am. And once again, I would like to thank you for joining us. And with your permission, I would like to conclude today's session. Thank you.
Thank you. And